Okay, good evening, all. We are going to be starting the second English session for our pediatric ECG arrhythmia seminars. As you know, we started 3 weeks ago. I alternate actually between Turkish and English every week. It's about 45 minutes. And you can share the link with others, whoever wants to join actually. So as you know, for those of you already joined, this is an interactive session. So it's very important to get your comments through the chat window. Please use the chat window. I look at that for your comments. You can send it to me, to panelists, or to me directly if you want, if you don't want others to see actually. Because this drives my seminar, being interactive is very important. It lasts 45 minutes, so let me start this week. As you know, we show you ECGs, different from different sources. Okay, we start with this patient. Okay, this, as you see, this is a 2-lead Holter. All right, let's get your opinion about what you see on the screen first. Waiting for your comments. I need to see some to be able to help. Okay. I guess you hear me well, right? If somebody can respond in the chat window to make sure things are working fine. Yes, good. So let me get your opinion. Okay, somebody said junctional rhythm, another junctional rhythm. Okay, any other opinion? Anything about P waves? Junctional rhythm with retrograde P waves. Okay, good. Excellent. So retrograde P wave. All right. So what you see here actually is so you assumed this is first of all you didn't see P waves before QRS. Therefore, because of that, you said it's junctional rhythm, right? That's a good assumption, but not always 100% true. Why? Because if you look at this QRS, it's slightly white, right? I mean, if this was an adult, you didn't ask me how old is this patient. Let's say this is newborn. For a newborn, this QRS is a little bit wide actually, and probably wide for a newborn actually. So if it was a wide QRS, it wouldn't be a junctional rhythm, like it would be actually a ventricular escape rhythm, okay? And it's quite slow. For a newborn, you know, around 70 beats per minute would be quite slow also. So quite slow ventricular escape rhythm is much different than a junctional escape rhythm, for example, right? It has different meanings. It has different significance. The other thing is, could it be still junctional rhythm with wide QRS? Is it possible? Let's say this is a 10-year-old and the QRS is much wider. No question that it's really a wide QRS. And it's like this, P waves after the QRS. Could it still be junctional rhythm? Answer? Any answers, please? It could be. How could it be? Junctional rhythm leads to narrow QRS, right? Okay. Let's say it's from AV node. Okay, from AV node or junction from his bundle. There has to be a bundle branch, not aberrancy, but bundle branch block. If the patient has underlying bundle branch block and the patient goes into junction rhythm, your QRS would be the same QRS as baseline. Okay, so let's see. Let's assume this patient is young. Okay, like therefore this QRS is a little bit wide. So it still could be junctional rhythm again, because maybe there's some block, right? How do we know? Like, how do I know this is junctional rhythm, or this is like a block, or this is ventricular escape rhythm? But what should I see, or what should I do? What kind of information I need to be able to say? Okay. Any ideas? This is Holter. One suggestion is look at other parts of Holter, right? That can give us a hint. Baseline, let's say this is baseline ECG. We do 12 lead. 12 lead doesn't help. It will show us wide QRS, maybe slightly wide QRS. Okay. A good suggestion is make the patient jump around. Excellent. Yeah, I mean, somehow, basically what you're trying to say is, make the atrium faster, right? or like if you can pace, like just suggested, somehow increase the atrial rate, okay? One easy way to do is to look at this is actually, if this is a telemetry, let's say this patient is recorded on a telemetry or in a Holter, you can see areas at, when the atrium is faster, okay? So this is another area on the same patient. So how does this change our opinion? First of all, is this, was this actually ventricular escape rhythm or not? Or now we know this is junctional rhythm or not? How do we know? So ventricular escape rhythm was one possibility, right? Is it still a possibility or it's not a possibility? Okay. No, it's not a possibility, right? Why? Because you see, first of all, we don't see retrograde P waves anymore, okay? These P waves come much later than like the previous one. So therefore, this is not retrograde P wave. This is a P wave. Maybe it's an atrial escape. We don't know, but maybe it's a PAC. But basically, still there's no normal sinus node. And also there's no retrograde, but the P wave comes somewhere towards the end of the T. And as you see, it's conducted with the same QRS. As soon as you see that same QRS, the ventricular escape is out of question. So therefore, either this is, if this is an old patient, maybe it's still junctional, maybe it's not that wide. If it's wide, it's bundle branch block. So therefore, we kind of rule out ventricular escape rhythm by just seeing the atrium. If this was a patient in the ICU, we see these situations a lot, actually. When you're not sure the QRS is narrow or not, first of all, always compare the ECGs to previous ones. This is very important, especially in operated patients, congenital heart disease, different types, in the ICU setting, ED setting. If the rhythm is not normal looking, especially if QRS is not normal looking, somehow different, that's true for everything. ST segment not normal looking compared to previous ECG. This is extremely important in our complex congenital heart disease patients. So let's say this was not available, this strip, we would still need to have this information. If in ICU we can atrially pace faster than this baseline rate, then we can know. Let's say this QRS would be narrow. Let's assume for a second, with these P waves, that's the junctional or whatever, we don't know, right? Let's say with these P waves, the following QRS was much narrower. Then our diagnosis would be ventricular escape rhythm, right? So these would be wider than, let's say, this one. Then it would be, okay, the P is conducting with a narrower QRS. Therefore, this was not coming from junction. So that would change everything. So somehow try to A-pace, or as suggested, if patient is able to jump around or whatever exercise test, one way or other, you can accelerate the atrial rhythm, okay? I think did we do this before? I'm trying to, maybe this one just came. I think we did this one before. Let me ask you, I'm not 100% sure. Did we do this in the first session? I think we did, right? Anyone answer, please? Do you remember this patient? You don't remember. Okay. One more person. Okay. At least few people don't remember. So, because I did this in the Turkish session last week, I wasn't sure about the English. So I have to be careful about which ones. Anyways, so this is a 16-year-old. As you see, a patient, AST closure using a device. Let's say this is, I don't remember the age. I mean, it's 16-year-old. I don't remember the details of the AST, but secondum AST, let's say. The age, as you see, 16-year-old. So what is that rhythm you see on the telemetry after AST device closure? Rate, as you see, is about 104. If you're not able to see, let me zoom. Let me zoom a little more. That's the rhythm. That's telemetry, by the way. Okay. So junctional rhythm, because it really looks narrow, right? Really not wide this time. There's no question for a 16-year-old. This is not a wide QRS. Any other possibility other than junctional rhythm? Okay, junctional rhythm. What type? Because it's a little fast, right? 104, so it's accelerated junction. That will be your first bet. always get a 12-lead ECG. Let's get a 12-lead ECG, and this is our 12-lead ECG. All right. Does this change our thinking or still junctional rhythm? Let me zoom for you the different areas. The rhythm strip is lead 2, like below. Okay. Let me unzoom. All right. Any other idea? First of all, yeah, okay. Some people are now starting to say there are P waves on T waves, and actually it's true. If I zoom, actually, look at the T waves, and there's relatively peak T wave. This is not a normal T wave configuration. Whenever you see something really sharp on a T wave, always be suspicious for actually a P wave, okay? So could it be first degree AV block? Okay, if this is first degree AV block, this is a normal speed paper. So we're talking about 200, what is this? 320 millisecond or almost 340 millisecond PR interval. That's extreme first degree AV block. Is this possible? In EP, a lot of things are possible. And look at this. I mean, there seems to be like there may be a P wave on top, okay? But, not 100%, okay? So we need to do more. We need to look at more. This is rest of the rhythm strip, another area. And just pay attention, like the rate here versus the rate towards the end. Actually, the rate slower is slower, right, towards the end. And you see the peak T wave now is changing slowly, gradually, and it's becoming softer and becoming like almost like a nudge. So you're seeing another wave coming out as the rate slower. Therefore, this should make you really suspicious that indeed, yes, there was P wave on T wave, and when the rate is slower, you can see the P wave out of the T wave. So therefore, it was first degree AV block. Just keep looking more. As you see, you will find nice areas. So therefore, in a telemetry or Holter, if you want to make a decision about such rhythms, it's critical to look at different areas. You cannot just look at this one and, like this, or especially like this, and just assume. Of course, you will have assumptions. You will say junction rhythm, whatever, that's normal. You have to have your differential, but you shouldn't jump into conclusion before looking at more. As you see now, I think there is no question in any of you, right? When the P waves, when it slows down, you see the P waves, how it comes out. And yes, it's, almost 400 millisecond PR interval. So it is possible because they are related, okay? So this was after a device, and it required some steroids, waiting. Patient improved slightly much later. So it took some time, and the device had to be removed. So sometimes you can stretch the AV node and you have to watch the rhythm. All right, so let's switch to another patient. This is a stress test, like beginning part, I guess, early part. And then the patient starts running more. So what do we start to see when the patient starts to run? The rhythm changed, right? Extrasystole, what type of extrasystole? So PAC, PVC, or PJC? PVC. Why PVC? Because they are white, right? They are not PAC, right? Why are they not PAC? Let's zoom. There's possibility of PAC with aberrancy, right? If you zoom, actually, let me zoom for you. Yes, there's some artifact because this is stress test, right? Usual. Look at the P waves. These are sinus P waves, like coming at expected time. The white QRS starts right after P wave, okay? It's kind of cutting, and some of them actually starting, look at this one, on top of P wave, right? So before the P wave ends, and actually it's not a PAC also. If this was a PAC and followed by a white QRS, then we would call them PAC with aberrancy, but that's not the case. If you time out, if you use a caliper, you will see that it's the same P wave, first of all, and then the P to P interval is the same, just the white curve is starting at different times. And also you can see the fusion, like when it's starting right after P, it's a little narrower. It's starting like at the top of the P, it's wider. So all speaks for the PVC. So what else we can say about this PVC? That it is with exercise, which is not good, right? So we have to think about possibility of CPVT. Any exercise-induced PVC, we should be worried. Yes, monomorphic. As we talked about this before, we need to think about the morphology. This has left bundle branch block morphology. And if you look at the PVC's inferior axis morphology, so it speaks for an outflow type. And we look at the transition of the R wave. If it's after V3, especially after V4, it speaks for RVOT. So far, what it looks like is a exercise-induced RVOT PVCs, and so far it looks uniform. So patient continues to run, and that's what happens. Now things changed, right? Especially look at the left precordials. Now you have lots of PVCs, and also the morphologies are changing, right? Let me see, is that the same patient we are talking about? Yes. As you see, when the patient is running. So therefore, it's kind of bidirectional appearance. So therefore, what is the diagnosis? Most likely diagnosis is CPVT, right? So it's very important to pay attention to these. Okay, let's assume this patient has a history of exercise-induced syncope. And let me see, let's say this patient is, let me make up a rate reasonable. Let's say this patient is an 8-year-old, okay, 8-year-old, exercise-induced syncope, okay, and this is the maximum, or this is the peak heart rate strip. After that, let's say there is recovery and the PVCs decrease and they disappear. So all what you see, let's say you don't see this page, there is no such page. This is the maximum you see, and the patient stops running, fatigued, whatever, leg pain. And then, in recovery, these PVCs are decreasing, and they're going away. So would you still say CPVT? Yes, would you still say CPVT? How would that be different? The patient is, let's say, again, exercise-induced syncope. Okay, let me, all right. So when you make comments, try to make it only to me, I think to panelists, okay? So that other people don't see your comments. This is better this way. Okay, so, okay, some people say yes, some people say no. There's a little bit of confusion. When I first showed you the last strip, everybody said CPVT. When I now change the story, you guys in general are not sure. Okay, this is also a very common situation, and you have to be very, very careful, okay? So what is the difference between this part and this part? The difference is patient is running more, and the rhythm is getting worse. So what is the expected heart rate for an 8-year-old when they do stress test, right? Look at this rate here. That's why I picked this heart rate, this age. It's about 150. That's not even near maximum effort. So the patient stops running early, may not actually show you what you want to see. This is very important. So you shouldn't assume that you did stress test fine. All what he has is just PVCs. And sometimes actually you may not even see this. There are patients who may start exhibiting only after the heart rate of 140, 150, they start having PVCs. These are CPVT patients actually. Therefore, you have to be very careful when assessing the actually a stress test. Did the patient reach the maximum acceptable heart rate? What am I looking for? So like in this patient, couldn't run more, you can miss actually CPVT. So therefore, anybody with exercise-induced PVCs, like in this case, even they are uniform looking, you still have to suspect CPVT actually and do things according to that, because there is still possibility, okay? Let's switch to another patient. Okay, this is whatever this patient D it says. Let me see. Okay, looks like this will be a stress test also. All right, anything catching your eye? I guess sinus rhythm, right? All right, let's see next strip. Okay, I guess there's more. Let's go more. And suddenly this happens. Same patient. First rhythm strip, again, you know, first ECG, I mean, this is exercise test. Starts running more. So what do you think with this? So on the baseline, anything catching your eye, or is it just a normal ECG? Okay, PR looks a little bit short, right? PR looks a little bit short, but indication was palpitation induced with stress test, this one. So yes, PR is short, but look at the QRSs. You know, you have nice Q waves in 2-3 AVF. You have nice Q wave V6, very sharp, steep onset of QRS. So there's no delta wave. The doesn't matter how short is the PR. So therefore, there's no pre-excitation here on this baseline ECG. Yes, it's short PR, but there's no pre-excitation. So this short PR doesn't have too much meaning, therefore. Here, again, just a normal looking exercise, you know, peak exercise or whatever. As you see, you know, there's J-point depression, but, you know, nothing pathologic. Still sinus, still, you know, acceptable. But suddenly patient goes into this, the QRS, everything changes, right? So how do you interpret? This is a patient exercising, and the rate up here is 190 beats per minute. So what do you call this rhythm? Okay. Is this SVT? Is this ventricular tachycardia? So how would you define it? I'm reading, okay, SVT. All right, good. So few people said wide QRS tachycardia, right? This is what your first reaction should be. You know it's a wide QRS, so you should say wide QRS tachycardia. So could it be SVT? Could it be VT? Yes, it could be all. For it to be antidromic, these are all possibilities. Let me see, there's more or not on this patient. No, there's not. This is it actually. So therefore, you know, first of all, some morphologies are kind of typical. So you have to define the morphology of wide QRS tachycardia. Okay, rate is 190 beats per minute. It's uniform. As you see, it's difficult to see P waves, right? At least we don't see like fusion. The rhythm is regular. This is also very important. So regular wide QRS tachycardia, right? P waves hard to see. At least we don't see fusion here. That's the rate. And then morphology. Okay, if you look at the morphology, which is critical, it's a right bundle branch block, right? And look at the 2-3 AVF. QRSs are negative, right? So going up. So this is quite typical for actually left ventricular, especially left posterior fascicular VT. That's one of the possibilities you have to think about. In left-sided fascicular VTs, especially the fascicular ones, posterior one, you expect like this superior axis and right bundle branch block appearance. If it was a left anterior fascicular VT, you would expect, you know, an inferior axis. So therefore, this is actually speaking for just because of the, you know, being a relatively common VT. This is one of the possibilities. Okay, for Mannheim, very unlikely to be Mannheim, but not 100% against Mannheim. So why is it so unlikely to be Mannheim? So first of all, why not WPW? Because very unlikely. Why? Because baseline doesn't show any pre-excitation. It's not 100% again, but because maybe this patient has intermittent pre-excitation, right? But it's unlikely for somebody with intermittent pre-excitation would be having antidromic SVT, right? But it is, again, not 100% out of question. So, so you're going through the differentials. So VT, left posterior fascicular VT, very unlikely to be WPW because baseline doesn't have it. There's another type of antidromic SVT, which is called Maheim, right? This is an accessory pathway with decremental properties. It doesn't have direct connection from atrium to ventricle. It's like through usually a right side, right bundle. There's a specific pathway that joins the right bundle. So it's a different type of pathway. Why is it very unlikely to be Maheim? Anybody knowing about Maheim? Okay. Yes, the bundle branch plaque, right? So Maheim fibers almost always, again, in EP, it's not always. There's always, some exceptions, but usually it's left bundle and like this, superior axis. The superior axis part fits. What doesn't fit is left bundle, right bundle here. So normally it should be left bundle. If you see a left bundle branch plaque tachycardia with superior axis, you should think about if the baseline doesn't have WPW, your first diagnosis should be not VT, it should be Maheim actually. VT still possibility. That here, left-sided Maheim is possible, but it's a very rare entity. I only seen like a handful of cases so far. So it is possible, but very rare. So therefore, VT comes out actually as one of the major possibilities. So let's say, so anyway, so these are the possibilities. Okay, so you give adenosine, this type of less posterior fascicular VT would respond to calcium channel blocker, for example, that can help. And then your treatment varies for your findings, of course, which is beyond our subject now. So we go to another patient again. A stress test induces this type of tachycardia. So what is the difference on this one? Again, stress test induced. This is the rhythm we see. Looks white QRS, right? Okay, is it uniform? Almost uniform, right? But what is different? Not quite exactly the same morphology. You see there are some narrow QRSs. So you should be suspicious whenever you see this of VT, right? Maybe there is sinus capture beats. Is there sign for fusion? Yes, there is some narrow beats. But what is the other interesting feature, actually, which doesn't fit to normal VT, I mean like common VT, the regularity, right? As some of you already pointed out, it's quite irregular. Look at this RR interval. It's so wide and suddenly becomes so narrow. So whenever you see irregular rhythm, okay, atrial or ventricular, always think about atrial fibrillation, okay? So during atrial fibrillation, how do you get this white QRS? What could be associating with this atrial fibrillation? What is the possibility? What is the most common reason? WPW, right? Very good. So, and that's how these patients die, right? Suddenly, they go into atrial fibrillation, and this is something we do when we do a WPW EP studies and ablations. Before we do any ablation or mapping, we assess for the risk of these patients. Risk meaning sudden death risk. We measure certain numbers, and we induce atrial fibrillation, and this is what we see. And we look at how fast it's conducting down the pathway. Sometimes we have these patients only have like very minimal pre-excitation, but then we induce rhythm like this, and even worse sometimes. And so the degree of pre-excitation doesn't tell us this patient is at low risk or not. If the pre-excitation disappears with exercise, it doesn't tell us that this patient is less risk or not. This has nothing to do with the risk. It's an old thinking. It's wrong thinking. So nowadays we ablate almost all of these patients with some exceptions. Again, this is beyond our topic right now. So therefore, irregular, white QRS tachycardia, uniform like this. Okay, you should be suspected of that. But of course, VT also possibility, right? You cannot say 100%, but such an irregular VT would be unusual. But this turned out to be VT, right? So your thinking was right. I just wanted to make sure you actually think about WPW, but indeed, this was VT induced at 13 minutes. How do we know? We did EP study, and we turned out to find that right aortic sinus origin, VT, and we actually successfully ablated. The thing that was supporting VT more here was this, actually the change in the QRS. You would expect more regular, more uniform looking. You wouldn't expect like this narrow bit in between, but again, it's not 100%. You cannot say for sure. And the way you would know is baseline doesn't have pre-excitation. The patient is not in pre-excitation, right? I didn't show you the first strips, right? Intentionally, because the first part of the stress test was not showing any WPW, right? So the question was at the beginning, if you see this, you have to think about atrial fibrillation. VT is another possibility. But if the baseline does not have pre-excitation, with this irregular rhythm, even though you see this in WPW, you should think about VT more. And this turned out to be VT. Okay. All right, let's go to so this is how we do it. Some cases are a little bit more difficult. Some things are really simple. Some things are quite complex sometimes. I do this intentionally so that people from all different levels can benefit. Not always simple, not always complex. So what do you think about this strip here, again, from a Holter? All right. Anybody? I'm not seeing yet any comments. Okay, AV blocked PAC, sinus with PJC, sinus exit block, Venkeba. Anything else? Non-conducted PAC, PJC. All right. So very good, excellent. Few things are right. So first of all, we have two sinus beats, right? And then we have a little pause. And what is this? Same QRS, okay? The same QRS actually is junctional. Why? There's a P wave, but still junctional. Why it's junctional? Because normally this patient conducts with this PR interval. It cannot shorten too much. This is too short. Like before the P wave ends, the same QRS starts. So it's not ventricular. So it's a junctional escape coinciding with the P wave. If this junction was coming a little later, the P would conduct, but the AV node couldn't wait anymore, or his bundle, and you have this junctional escape. Same here, junctional escape. All right, we understand that part, like it happened here also, here also. What's interesting is that, few times you have like a certain rate for sinus, and suddenly you have a pause. And after the pause, what pause? Sinus pause, right? After see this P comes so late. After the pause, you have this junctional escape each time, sinus pause. So why this patient has sinus pause? Some of you said maybe it's sinoatrial exit block, right? What is the other possibility? Few of you mentioned 6 sinus. I mean, a form of, again, could be sinus exit block. All right, as some of you mentioned already, just for the sake of the time, we have 12 minutes to finish. Look at the T waves actually, just before the pause. Compare it to the ones before, okay? I know it's difficult. Let's zoom. We like things on T waves in EP. Always remember this. And always compare any ST segment T wave to the ones with the sinus. So the first one looks a little bit peaked, right, compared to the other. Look at this one. Maybe there's a notch here. And again, this is different. Okay, maybe this is coincidence, right? Maybe this T wave, maybe there's an artifact or something possible. So how do you differentiate? Again, in EP, to say something not coincident, look at different parts. Do you see the same phenomena? Then it's not coincidence. Then it's not artifact. Let's look at this one. 2 normal sinus beats. Okay, this is junctional, but no 2 normal T waves, ST segment. And suddenly, look at this. And very nice, actually, this time, possibly P wave. Okay, do I see it again? Yes, look at this. I see it again. Again, with the other ones, I don't see it. When it's junctional or sinus, I don't see this thing. I see it just before the pause. Again, see, I see. So there is for sure a PAC. Therefore, the reason for actually this slowing part was not sinoatrial exit block, not sinus node dysfunction. Actually, it was PACs blocked, resetting the sinus node, resulting in junctional escape rhythm. That's all what we see, okay? Even this P waves are not conducting, okay? Because it's too short, like this is too short. All right, let's go to next one. This is, all right. That's onset of a tachycardia. So always, we mentioned this before, we have to focus on how a tachycardia starts. So this is a narrow complex tachycardia, therefore it's SVT, not sinus, right? How does it start? With a wide QRS, possibly PVC. There's too much artifact here, but most likely a PVC, unless it's a aberrantly conducted PAC. And what type of tachycardia is this, right? We look at the P wave location, which is late, right? So after the RR intervals midline. So long RP SVT. So this is, we have to say this actually long RP SVT started with possibly a PVC. And always look at the end also. How does it end? With the P wave. Why is it important? Like, for example, long RP SVT, what is the most common long RP SVT that we see? Long RP, again, the P coming late, most common type. Focal atrial tachycardia, right? Some people also call it ectopic atrial tachycardia. I said SVT, not sinus. Yes, most common long RP tachycardia is sinus tachycardia. Most common supraventricular tachycardia with long RP is not sinus because it's actually SVT by definition. So focal atrial tachycardia is the most common type of long RP SVT. And what does this rhythm strip the way it stops tell us actually about possibility of others are PJRT, atypical AVNRT like that. But focal atrial tachycardia is more common. So by seeing the P wave ending like this, actually we rule out focal atrial tachycardia. So simple. So this is why it's very important, like when somebody shows you a rhythm strip, okay, long RP tachycardia, if they just show you this, like this, okay, focal atrial tachycardia, number one diagnosis, atypical AVNRT, PGRT, like that, okay? So this is why when we receive Holter strips, as electrophysiologists, we always want to see how did this start and how did it end, okay? Because, if they just give me this page, and a lot of times I don't see it because a lot of people don't know where to look. We have to look at the beginning and end. By seeing this end with a P wave, I rule out the most common cause actually, focal atrial tachycardia. This changes everything because the way I will approach this, for example, this becomes much more actually ablatable tachycardia in a young child. Why? It's a long story, but most focal atrial tachycardias, if they are not frequent, actually they're suppressed with sedation, anesthesia in young children, and a lot, we have less success rate compared to, let's say, PJRT or atypical AVNRT. So, I mean, it changes your management, it changes your approach, just seeing this. Why this is not focal atrial tachycardia? Because if it was focal atrial tachycardia, this last P would conduct the QRS and it would end with a QRS. If it ends with a P and the tachycardia is stopping same time with an AV block, extremely unlikely, right? So this P should conduct and then it should stop. Then it is possible to be, still, it doesn't say it's focal, but focal would be a possibility. So ending with a P wave in a long RP tachycardia rules out, again, pretty much rules out, atypical, focal atrial tachycardia. All right, next patient. So what do we see here? Sinus, most likely sinus, we don't know, 3-lead Holter, and then some extra beats. Let me see, do we have more? No, looks like we have only one rhythm strip. All right, so we have 2 extra beats, and what are they? Let me zoom more, so you see better, I hope. Okay, like this, okay. One is green, one is red. Any comments? What type of early beats they are? One is PAC, one is PVC. What do you think? Okay. For the sake of time, I guess you agree this is PAC, right? Why? Always, when you see an early beat, again, look at the area before this QRS and look at on all leads that's available. If you just look at this one, okay, how do you say there's a P wave? I cannot. I mean, I've been doing this more than 20 years. I cannot. I mean, I can be a little suspicious, but I cannot. But if somebody shows me this, then I can, because look at this. But what if this is artifact? Again, like the previous comment I made, if this is artifact, it shouldn't recur the same way. That's how we will differentiate. But look at the previous areas during sinus, the STT segment, even though there's some variation, we don't have a notch like this. But what if this notch is coincidence coming from this extra? Okay, let's look at another one. And actually, same thing here, see? And then the early beat. And indeed, here you have looking like PVC, but it's not PVC because there's a P wave preceding it. So therefore, it's aberrantly conducted PVC, and this is normally PAC. And this is, so they are both PACs, okay? One is aberrantly conducted. Okay, what is this one? All right, so I don't know. This is a H, I don't remember. But what do you think about this rhythm strip? Okay, another patient. Yeah, let's make up an age. Let's say this is a 7-year-old. So rate is a little bit slow, right? Okay. Something strange. Okay. So few of you, again, for the sake of time, saying that some of you saying there are some PACs, and some of you are saying that this is 2-to-1 AV block. Okay. So these are the first possibilities we should think of whenever we see additional P wave not conducted, right? And first of all, you should see this, of course. How do we see that? Because look at the T waves, they are not normal. And there's change in the T wave morphology towards the end, and there's a notch. So you should suspect that there's a P wave here. But again, to know more, you need to look at different areas of the rhythm strip. So when we continue to look, and actually I intentionally hide from you from the third lead. This is cut, actually. This was a 3-lead halter. So I did cut, actually, the third lead. I wanted to make comment, because this is what you may be seeing, just these 2 leads, or even 1 lead on the monitor, right, in the telemetry. So this is why doing 12-lead ECG, getting simultaneous different QRSs or leads is very important. So if I add you the third lead, then I guess all of you will say, okay, there's a P wave here for sure, right? Look at this. Okay, this should be like that, actually. Yeah. So again, now 2 possibilities. One, PAC. Other actually is sinus. And if you look at it, actually, it looks like the same P wave, pretty much, at least on this lead, comes about the same time. So in this case, it looks like 2-to-1 AV block, right? So it's all about timing. All right. So same patient, different areas. You see it's normal conduction, and suddenly you have a blocked PAC, and patient goes into 2-to-1 AV block, like one conducted, one not, before it's conducting normally. So this is a patient with 2-to-1 AV block. Again, different areas, same P waves, PP interval stable. So therefore, this is not a PAC, right? And here it's more block, actually, right? 3-to-1. And so this patient trying to do complete block, right? Again, 2-to-1 goes to 1-to-1. So switches between different ones. Okay, very good. So let me see. This is, all right, this is another patient. Looks like patient M. All right, so anything? WPW, right? So if you look at it, okay, the first lead, a little bit suspicious, but if you especially look at the second one and especially third one, both of them, you should say WPW. All right, so far, looks sinus. And then then what happens? Suddenly something changes, right? What did change? Pre-excitation, okay. What happened? Okay. Is it intermittent? All right. Because the QRS changed, right? Became narrower. Did pre-excitation disappear? Look at the first lead and second lead. It's interesting, right? If you look at the QRS on the first one and second one, look at all three leads. Do you think it's intermittent pre-excitation still? Less pre-excitation? Okay, if you say less pre-excitation, I will debate with you. Look at the first lead, it becomes more pre-excitation. So how do you explain? So some of you said less pre-excitation because they are looking at the third lead, which they seem right. But look at the first lead, actually it's more pre-excitation. What should you think about this when you see? While you're thinking, let me continue. This is another page. Is there any pre-excitation here of different type? Maybe. Not really. Actually, this looks more like bundle branch block, right? Look at the PR interval, pretty clean onset of QRS, some rate-related bundle branch block. So what is the diagnosis? Ebstein, right? So Ebstein patients tend to have more than one pathway, and this is what you're seeing actually. You're seeing intermittent bundle branch block. You're seeing changing in the pathway. The patient has multiple pathways. These patients are especially at more risk. So again, if you look at the first lead, it's not intermittent actually. The QRS here seems to have less pre-excitation, but the QRS up here seems to have more pre-excitation because the shape changes. So if it was really intermittent, you would have all narrower QRSs on all three leads. So whenever you see a change in pre-excitation, the change in the QRS with short PR, you should think of multiple pathways, which is higher risk actually in any patient, even more so in a patient with Ebstein, right? So you have to be careful about that. So it's already 9:02. I'm trying to limit this to actually 45 minutes. Again, for those of you just joining, 1 week Turkish, 1 week English. So next week will be a new Turkish session. I think there's from Congenital Heart Academy, again, you can join the link or you can watch later, or your colleagues can watch it later if you go to Congenital Heart Academy. And so hope to see you next time, probably in 2 weeks with the English version. So I'm ending it here. Thank you very much for those of you who joined. Take care and have a nice week.